Hello, I'm Dr. Donald Jurivich, and today's presentation is on age-friendly healthcare and the 4M of mobility. This is part 2. I'm a University of North Dakota professor of geriatrics and also the principal director of the HRSA-funded Dakota Geriatric Workforce Enhancement Program, a little bit of a mouthful, and I just wanted to alert you to the web page here listed at the bottom called Dakota Geriatrics, which has a copy of this presentation and some other resources for education on geriatrics and age-friendly healthcare. So in this part 2 presentation, we want to look at how do you do a fall risk assessment and how do you create an action plan to intervene. And I just want to comment here about Mr. Carl Walanda, who's passed away from an accident from a high wire act, but just really to me represented as from my childhood, just an amazing performer in ability, both he and his family, to balance. And so it just shows you what the highest level of balance might be. In terms of goals for this presentation, we want to look at how to do fall risk assessments. We want to consider the multiple reasons why a fall may occur, and then we want to create an action plan. So please answer the question here. What is the most effective fall reduction intervention? Is it weightlifting, stretching, walking, yoga, or a multidisciplinary team assessment? In terms of fall assessment, they can be broken down generally into 2 categories. One is what we call the rapid screen, and then the other one is a little deeper dive that involves static and dynamic balancing. And in terms of the rapid screens, certainly the self-report or a report of fear of falling are both very, very strong indicators that the individual will fall again in the future. We like to use a very quick balance test called the Sharp-and-Romberg test. We'll discuss how to do that. And then also gait speed is a very, very powerful measurement of not only fall risk, but also dementia risk. And then we're not going to talk too much about the 1080 gait scale, balance test. We will talk shortly here about the Berg scale, which is typically performed by physical therapists. So the Berg scale is 14 different tests, so it takes a little while for the older adult to complete this test. And each one of these tests is scored on a 0 to 4 scale as to whether they can do it or not. And so the higher the score for these 14 tests, with 56 being the maximum points, would indicate a low fall risk, whereas a score under 20 would indicate a high fall risk. And I just give you an example of one of the tests here, which is a 1-minute sit to stand test. How many can you do? And that's based upon your age. And this graph here shows you that the performance on the Berg scale does go down on average with age. And so you can see the 90-year-olds have a Berg score of just under 40, where the 60-year-olds pretty much will score a Berg scale of over 52. So, and again, that's on average. Now, clinically, I think, for the non-physical therapist, using the Sharp-and-Romberg or the tandem stance is the way to go. Basically, on the little picture here, you can see it looks like a dance pattern here, as to how you learn how to dance. But basically, you put 2 feet together. You then have the individual put 1 foot next to the other one, a little, one leg forward, and then eventually you put 1 foot in front of the other. It's almost like a sobriety test, quite honestly, and some people will actually try to walk the line. You don't want them walking, you just want them to stand still. And typically you start off with a test with the dominant leg in the back. If there's some obvious hemiparesis or weakness that you already know, you don't have to perform this test because that individual will already be a fall risk by just virtue of that leg weakness. So in the picture here, you can see this therapist who's demonstrating crossing her arms. So that's the official test. to be perfectly honest with you, older adults that can't maintain this heel-to-toe stance don't need to cross their arms because they're going to be wobbly right from the get-go. But again, if you want to be authentic with the test, you should have them cross their arms, and the test should be done with eyes both open and then eyes closed, and you wait for 10 seconds to see whether they can hold that stance. Okay, so we've done our screening, which, by the way, I wanted to mention that gait speed is also another way to do the test, and that's my preference, quite honestly, because people with a gait speed of less than 1 meter per second have a high risk for falls. But anyways, we want to talk about the approach to the older adult who has been screened positive for fall risk. So the first thing to do is review the systems. And so if they had a fall, you want to see how that fall related to getting up out of bed or out of a chair, whether it was related to when they took their last pill, and also whether they had a post-meal either fainting spell or fall. They may not say that, oh, I fainted, but they may have gone to the ground after about 30 minutes to 60 minutes after eating. And then you want to look for environmental factors. Were there any changes in surface going from a hard surface to a rug or soft surface, for example? Something in the bathroom, no grab bars. Maybe they fell while trying to get onto or off of the toilet seat because it wasn't high enough. And then you want to ask if there's any general fatigue or weakness, any legs that feel weak or give out on you, such as, a lot of people describe having their knee go out on them. And then also ask them about lightheadedness or spinning. And then finally, in the review of systems, it's always important to consider whether the individual's consuming alcohol or not. And that's true in any setting. I've seen people who, family will bring them a little nightcap or something to that effect in both nursing homes and in hospital settings. Not so much in the clinic, but I have seen people who's come to the clinic inebriated. So it's, you always have to ask that question. In terms of the physical exam, you want to focus firstly on the neurosensory, so doing an eye chart test or a Snellen test, both with glasses on and glasses off, hearing test, and also looking for cerumen impaction is really important because the beeswax in one ear to both ears can be a problem for gait and balance. In terms of the musculomotor exam, I like to do a shoulder shrug, and if they have any weakness there, that could indicate some central weakness. I check for their arms for cogwheeling and seeing if there's any ratchetiness that's associated with Parkinson's-like syndromes or disease. I look for motor strength, again, the shoulder shrug, the arm. So you always look for the upper extremities as well as lower extremity strength, both in terms of the hip strength, knee strength, ankle strength. And I also look at the greater toe strength. And so if they have weakness in pushing the toe downwards or upwards, that could indicate a lumbal fifth nerve problem or a sacral first nerve problem. And then I also do range of motion. And you can see in the picture or diagram here, person lying on their belly, and you pick their knee up and see how much range of motion they have. A lot of times you'll find that psoas stretch to be limited. In terms of the neurologic exam, it's important to see if they have vibratory sense in their feet, proprioception, so 2-point discrimination, as well as soft touch. Particularly in diabetics, you want to do the monofilament test to see if they have any sensation in their foot. And then most importantly is to do the mental status test, like, do they have memory loss, either by doing the St. Louis University mental status test, what we call the slums, or you could just screen the person for memory problems just by asking them to name as many animals as they can do within a minute. And if they can't get more than 15 animals named within a minute, then it's likely that they have some sort of memory loss. So once you've done the assessment, you want to create some interventions. And one of the new observations is that People should not wear bifocals or progressive glasses if they have a fall risk. If they have wax or cerumen impaction, that should be removed. And then you should start a program of resistance training, which, by the way, only requires twice weekly, either weights or stretch band for resistance training. And then you also do core balance training, so that might involve under supervision, standing on one leg, or some people call that the yoga tree move. Flexibility is important, and it's not necessarily proven to reduce falls when you increase flexibility, but it is an important component. And one way to promote flexibility of the hip is to have the person place one foot further out from the other foot, and then with the opposite arm bring it up over their head, and that'll help with back stretching. Ultimately, if you are able to refer the patient to a geriatrics program or a fall prevention program, is ideal. And then if the individual is community dwelling or in assisted living, for example, referring them to a community program such as Stepping On or Bone Builders is proven to be very, very highly effective in preventing future falls. So further action plans might include either prescribing an assistive device or fixing it. I can't tell you how many folks I see come in with their rolling walker and the brakes just don't grip, and it just needs a little turn on the brake cable. I mentioned here Nordic sticks and show a picture here. So it turns out that Nordic sticks are pretty good for increasing energy consumption. So if somebody wants to go walking and get a little extra oomph out of, for weight loss, Nordic sticks will help do that. But they also provide balance. So it's important to realize that when we grab onto something like a cane or a stick, it settles the brain. It tells the brain, I've got something to hold me steady. And then you don't get all that kind of jittery motion and that wobbliness that actually can help or contribute, not help, but rather contribute to a fall. In the long-term care setting, vitamin D supplementation at 1,000 units per daily is considered an intervention to help reduce falls. It's not so clear in the outpatient setting whether it works. And then also, I call this home environmental check, but that could also be in long-term care, also looking at room clutter, and also, again, just remembering those transitions from a hard surface to a soft surface like a rug are often the points where you can catch yourself. So if somebody screens negative, for a fall, there's some referrals I had already mentioned about referring them to Stepping On or Bone Builders. If you live in North Dakota, you can consult this website called NDC3. That's actually being reworked, but it's a health promotion site. And then also the National Institute on Aging has home programs for resistance and core and endurance training. And I'll just mention, we'll come back to this at another presentation, but new research study shows that just simply doing 10 minutes of getting your heart rate up improves cognition by 10%. Conversely, sedentariness for that exact amount of time reduces cognitive performance by 1%. And so remember the connection between cognition and gait and balance. And so anything that we can do to improve cognitive function, such as these 10-minute bursts of exercise, is really good news, for promoting that, because it doesn't take much to make a difference. And in fact, just as another side comment, that if you have somebody simply stand up and sit during commercial breaks while watching TV, it's possible that they can reduce their hemoglobin A1C by a whole half point. So again, it doesn't take much to get people moving and to get health benefits from that. Some of the emerging concepts, I like to prescribe what's called dual task training. And so that involves cognition and walking, basically. So you walk and you ask the person to count backwards or say the alphabet backwards. And that's been proven to increase postural stability and reduce falls. The second point there is what's called single session gait perturbation. It's a little bit of a mouthful, but just suffice it to say that people will do therapy with the older adult by tossing them a fairly heavy medicine ball, and they've got to catch it. They're on a bungee cords, and they're supported, or they may be on a treadmill that stops suddenly, and again they're on a bungee cord. But that process of perturbations and pushing them and forward and causing trip falls is a form of therapy. So I would just like to summarize that we know that age alters posture. It starts to slow gait speed, and our recovery strategies when we have a gait perturbation are altered with aging. We can do a rapid screen for falls by doing either gait speed or the Sharp-Romberg. And again, I prefer the gait speed just simply because it is a risk factor for not only falls, but it's for hospitalization as well as for future memory loss. And then finally, we want to create an action plan, and that action plan depends upon patient-specific problems that are identified through a very systematic, almost checklist fashion of asking all those questions that we talked about. So thank you for your attention, and I'd like you to complete this, no, it's actually a post-test, I'm sorry, I put pre-test presentation. The most effective fall reduction intervention is which of the following? A, weightlifting, stretching, walking, yoga, or multidisciplinary team assessment. Thank you for your attention.